Good evening for those in India and an early great morning for those in the West. We at Aravind Eye Care System welcome you all to the Dr.G Venkataswamy Memorial Oration and Award Ceremony, a momentous occasion for all here, celebrated year on the birth anniversary of Dr. V. Despite the untoward pandemic, we are here to celebrate this occasion on a virtual platform with the entire network of Aravind Eye Care System connected from various locations and many viewers across the country and globe witnessing the live streaming of this program. A light of compassion and healing, a visionary and an inspiration responsible for today's revolution in providing vision to millions in India and setting the example for others around the globe, Dr. V lives forever through all those he touched and served. To mark his 102nd birth anniversary, let us observe a moment of silence followed by a prayer by Mr. Sanil, a faculty at LICO.
सर्वेषां स्वस्तिर्भवतु सर्वेषां शान्तिर्भवतु सर्वेषां पूर्णं भवतु सर्वेषां मङ्गलं भवतु असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मा अमृतं गमय ॐ शान्ति शान्ति शान्तिः
I request our chairman of Aravind Eye Care System, Dr. R.D. Ravindran, to welcome the virtual gathering for this momentous occasion and speak a few words on the legendary Dr. V.
Good evening, everybody. Dear David, respected senior leaders and founders of Aravind Eye Care System, fellow doctors and staff of the various units of Aravind Eye Care System, friends and supporters of Aravind, I have great pleasure in welcoming you all for the Dr.G Venkataswamy Memorial Award Ceremony and Oration on his 102nd birth anniversary. On this occasion, it is my pleasure to especially welcome Dr. David Chang, his wife Victoria Chang, his family and friends from all over the world who joined this celebration virtually. Dr. G. Venkataswamy, fondly called by all of us as Chief, was a person who understood the purpose of life early on in his early days, and he was a realized soul. He was a patient-centric doctor, has been a role model for compassionate healthcare, and has been constantly looking for ways how to create access for patients through eye camps and later through opening several eye hospitals in several locations. And we are happy to share that during this COVID pandemic, he opened our 80th Vision Center in a small village near Tirunelveli, which is incidentally the 100th patient care facility for Aravind Eye Care System. During this pandemic that has affected everyone, the values laid by Dr. V and the founding members has helped us to take correct decisions which enabled us to deliver the best possible care to all our patients and keep our facilities for uninterrupted access to the patients who come for eye care. Keeping the same values, We had done all that is required to protect our staff from COVID-19. Every staff member of the organization, including those in support services, did their best in spite of the fear we all had for the COVID virus. Right from planning for this COVID pandemic to staffing the services with appropriate people, we had done it in the same spirit as when Dr. V was alive. Celebrating such a person's birthday is a joy to all of us. On Dr. V's birth anniversary, we have been organizing Dr. G Venkataswamy Memorial Oration since 2009. This is to recognize and honor outstanding people who have contributed a lot to ophthalmology and community eye care in order to eliminate needless blindness. So this year we are honored to have Dr. David Chang to receive this year's Memorial Oration Award, and I thank him for accepting it. Thank you, David. For Dr. V, the hospital should care for the whole person to offer comfort, relief, as well as eye care. Dr. V strongly believed that we can realize the full potential of modern technology only when it is combined with compassionate care. It is this belief that keeps us conducting over 3,500 eye camps year after year, and also helped us to expand our facilities to over 100 locations. It is again this compassion Dr. V had for all those who are blind across the world that got Aravind into the capacity building work through Lions Aravind Institute of Community Ophthalmology and also in starting Oro Lab. The work started by Dr. Venkataswamy in starting the Lions Aravind Institute continue to grow, and today there are over 360 eye hospitals that are mentored by LICO, contributing to nearly 1 million additional surgeries. And in addition, over 10% of the patients who undergo surgery all over the world are touched by the quality products which are made from Oro Lab. It is the same passion now helps us to contribute to the scientific evidence for treating the eye diseases through AMRF and Dr. G Venkataswamy Eye Research Institute, and also through the clinical research, some of which have helped to improve the care received by the patients all over the world in a very significant manner. Dr. Venkataswamy always talked about doing the work with compassion, with the best quality, and without any egoistic attitude. Dr. David Chang is one such person, a role model for the younger generation. So we all know in Aravind, Dr. David Chang since 2003, when he was invited to Pondicherry by Dr. Venkatesh for a CME. So since then, the ongoing collaboration work with David has significantly influenced the way we treat patients for cataract for the last 15 years. We are happy that David is being honored today with this award and delivered this year's oration. So welcome all of you who have joined virtually to celebrate the birth anniversary of Dr. V. We also thank all our friends, collaborators, eye care NGO organizations for the continuous support to Aravind to realize the vision of Dr. Venkataswamy. Thank you.
Thank you, sir. A visual depicting Dr. V's vision, simplicity of purpose, his desire for never-ending improvement will be played through a song sung by Sanil, written and composed by Mr. Prabhakar. Let us view the drop of light.
ஒரு துளி வெளிச்சம் பெரும் வெடிப்பாகும், ஒரு துளி கனவு உலகினை மாற்றும், ஒரு விழி திறந்தால் பல இதயங்கள் பூக்கும், இதயங்கள் பூத்தால் உலகமே சிரிக்கும். ஒரு கனவை நெய்தவரே, பெரும் கனலாய் நின்றவரே, வரும் காலம் கடந்தவரே, பெரும் வரமாய் வந்தவரே. வார்த்தைகள் துயர் களைய உறுதிகள் பூண்டாய் பேரன்பாலே பெரும் செயல் செய்தாய். ஒரு கனவை நெய்தவரே, பெரும் கனலாய் நின்றவரே, வரும் காலம் கடந்தவரே, பெரும் வரமாய் வந்தவரே.
Dr. G. Venkataswamy Oration and Award was instituted in 2010 to recognize and honor individuals who through their work have significantly contributed towards eliminating blindness. Presenting to you the distinguished winners of this prestigious award in the preceding years. We are now pleased and happy to announce the award winner of this year 2020, Dr. David Chang. May I now request Dr. Haripriya, Head of Cataract Services, to read the citation for us.
David F Chang, MD, a summa cum laude graduate of Harvard College and Harvard Medical School, is a world-renowned cataract surgeon at the Altos Eye Physicians, California, and clinical professor at University of California, San Francisco. Having chaired the American Society of Cataract and Refractive Surgeons ASCRS Cataract Clinical Committee and International Committee, Dr. Chang has been on the ASCRS board and executive committee since 2009. He served as its president in 2012-2013. In addition to the Lifetime American Academy of Ophthalmology Achievement Award, Dr. Chang is a 6-time AAO Secretariat Award recipient. Dr. Chang, a surgeon par excellence, has imparted fine surgical skills to ophthalmologists around the world. He has traveled to many developing countries to perform and teach cataract surgery to local ophthalmologists. His courses in AAO, ASCRS and ESCRS on phaco-chop and complex cataract surgery have been much sought after and well received by ophthalmologists the world over. Dr. Chang has authored several textbooks including phaco-chop, curbside consultation and cataract surgery, mastering refractive IOL surgery, and advanced IOL fixation techniques, which have helped the current generation of ophthalmologists to significantly refine their surgical techniques. Having authored over 100 peer-reviewed publications, including his landmark work on tamsulosin and IFIS, and widely regarded as a key opinion leader, he is regularly invited to write editorials in high-impact journals. Dr. Chang has been very supportive of the humanitarian work done by organizations like the Himalayan Cataract Project, Tilganga Eye Hospital, and Aravind by highlighting their work in various international platforms. Dr. Chang has delivered more than 40 prestigious named lectures. He has been honored by ophthalmology and cataract societies across the world, including the AAO Kelman Lecture, ASCRS Binkost Lecture, ESCRS Ridley Medal, Asia Pacific Association of Cataract and Refractive Surgery Limb Medal, United Kingdom and Ireland Society of Cataract and Refractive Surgery Rayner Medal, and All India Ophthalmology Society President's Lecture. Dr. Chang has been regularly voted into the national edition of Best Doctors in America. He has been named in every biennial list of the top 100 most influential people in ophthalmology as voted by the international readership of The Ophthalmologist. Dr. Chang visited Aravind in 2003, which was the beginning of a historic relationship with Aravind. He was convinced that Aravind's high-volume, efficient, cost-effective MSICS technique was a sustainable solution to address cataract backlog in the developing world. He rallied with his home regulatory authorities and ophthalmic societies to include flash sterilization to reduce waste and improve operating room efficiency based on Aravind's practices and outcomes. His editorial in BJO 2005 on tackling the greatest challenge in cataract surgery and Binkost's lecture at the ASCRS opening session on the greatest challenge in cataract surgery, a 5-minute $15 cure for blindness focused on Aravind and Tilganga models of providing high volume, high quality, cost effective cataract surgery. Dr. Chang suggested the introduction of intraocular antibiotics as prophylaxis to reduce postoperative endophthalmitis and square edge design of PMMA IOL to reduce posterior capsule opacification. He worked closely with Aravind and Orolab to roll out these two significant interventions. He also collaborated with numerous Aravind faculty and co-authored landmark publication on Aravind's best practices, including operating room protocols, short cycle sterilization, intracameral antibiotic prophylaxis, MSICS outcomes in challenging cases, surgical complication rates, square edge PMMA IOL, and reducing operating room waste and carbon footprint. Surgeons from Aravind attending the ASCRS and AAO visit Dr. Chang and benefit from his personal teaching and his example. They are inspired by his surgical skill, humility, and passion to challenge the status quo. He constantly looks for ways to be helpful. For example, to enhance the cataract surgical learning experience at Aravind, he donated a 3D visualization video system, which was the first of its kind surgical teaching aid in the country. Besides being a teacher and mentor, David is a great friend and generous human being who never misses an opportunity to host Aravind colleagues when they visit the US. Dr. Chang currently co-chairs the ASCRS Foundation and was the recipient of the 2009 AAO Humanitarian Service Award. The honorarium he receives through selling his books is donated to eye care charity. With a focus on global ophthalmology and to acknowledge humanitarian work, David and his wife Victoria Chang established the ASCRS Foundation's Chang Humanitarian Award to honor and recognize outstanding humanitarian work in the area of cataract blindness. The award is given annually to an individual for their inspirational accomplishments in the US or international charitable eye care. The $50,000 prize money is awarded in the recipient's honor to a charitable eye care organization of their choice. Aravind Eye Care System is proud and privileged to confer the Dr.G. Venkataswamy Memorial Award for the year 2020 on Dr. David F Chang in appreciation of his contribution towards teaching, training, and improving quality and outcomes of cataract care worldwide.
To celebrate this award bestowed on Dr. Chang, the renowned ophthalmologist Jeff Tabin, a close friend of both Dr. Chang and Aravind, is here to sing a poem describing Dr. Chang, composed in the tune of American blues, a very different and a very popular slang. This will be followed by handing over the award, which will be virtual and of course magical, with the award crossing countries. I request Mr. G. Srinivasan, President, Global Trust, Dr. Namperamal Swamy, and Dr. R.D. Ravindran to hand over the trophy from India, and Dr. Tabin to present the trophy to Dr. Chang in San Francisco. Over to Dr. Tabin.
The gypsy woman told his mama before he was born, "You got a boy child coming, gonna be a son of a gun. He will take blind people and make them all see." And the world want to know, how can this be? But you know him. Everybody got to know about him. He's the David Chang man. Everybody knows he can. Born in Baltimore, excelled in school, Phi Beta and Summa at Harvard. He ain't no fool. Became an eye doc, great husband and dad, but it's his curing the blind that while staying humble and kind, that makes the whole world glad. That makes the whole world glad, people. You say you don't know him? Everybody got to know him. He's the David Chang man. Yes, people, you know he can. Chang's got compassion, just like Dr. V, and a passion for teaching, even across the sea. Always selflessly serving, ain't no one more deserving of giving the G Venkataswamy Endowment Oration. So let's start the celebration. Everybody knows him. Yes, you know him. He's the David Chang man. Yes, David Chang can. Yeah. And really, there is no one in the world more deserving of delivering the Govinda Venkataswamy Oration than David Chang. And no one really has demonstrated the heart, the compassion, and love of Dr. Venkataswamy in my life more than David Chang. So it's an incredible honor to present you this oration.
Thank you. First of all, receiving the award is certainly one of the biggest surprises of my career, and it's certainly, this path is not something I ever could have planned or predicted. So first I have to thank you, Jeff, because you're not only a personal hero and a personal mentor, but you've really taught me so much about global ophthalmology and helped set me on this path. And it's such an honor to have you be the one to help Aravind in this ceremony. Of all the honors, I have to say this one is extremely special, and that's because there's really no institution in the world during my career that's done more for ophthalmology than the Aravind Eye Care System. And I just have so much honor and respect and admiration and love for all of the group at Aravind. So I just want to thank everyone, the board at Aravind, and what an honor to be able to honor Dr. V. So thank you very much.
Without much ado, I invite Dr. Chang to deliver the most awaited Dr. G Venkataswamy Oration lecture, Lessons Learned from the World's Greatest Team of Cataract Surgeons.
Well, thank you so much and good evening. And thank you for that introduction. I think it's made me speechless, but so the challenge will be now to give my lecture. I do want to thank the Aravind Trust and the Aravind leadership for this very special privilege of delivering this lecture in honor of Dr. Venkataswamy. And what a wonderful tradition this is to honor Dr. V annually on October the 1st.
Well, let me first explain the title. So I've written about the fact that for those of us practicing in the most advanced healthcare systems, such as in the United States, we can still learn important lessons from those practicing in medium to low resource healthcare settings and countries. In eye care, I would argue that Aravind leads the world in terms of efficiency and cost effectiveness and innovation in healthcare delivery. You are number one. And what's the secret? You've achieved this because of selfless teamwork, putting individual goals and recognition aside. And everyone embraces the institutional values of compassion, quality, integrity, and being self-sustainable, that is, not relying on others for funding. And it is this culture and these values that make Aravind so unique, and they are Dr. V's true legacy. Now, coincidentally, tomorrow morning, I'll be giving the Ridley Meadow Lecture to open the ESCRS annual meeting. And although this is another award to recognize an individual, I'll be using this platform to tell that audience about Aravind, the greatest team of cataract surgeons in the world. And hopefully many more international ophthalmologists will hear the Aravind story tomorrow. As was mentioned, my journey with you started in 2003 when the Pondicherry Hospital had its grand opening. And I was there to give a lecture to the Pondicherry Ophthalmology Association. And here is a scene informal between cases with, of course, who would turn out to be Aravind's future leadership and true stars. This has led to such a wonderful collaboration. The story of how I got there is really through Dr. Venkatesh, who, when he was visiting SEVA in Berkeley, California, had wanted to visit the highest volume cataract surgeon in the San Francisco Bay Area, and so he came to see me. And I was showing him how, by going in between two different operating rooms, I could do 4 cases an hour. And after a few hours of this, I turned to him and said, well, how many cases an hour do you do? And he said, well, it depends. Probably 14 to 16 an hour. So, that was my introduction to high volume surgery. And although I came to Aravind to teach phaco and phaco chop, I came away just simply amazed at the efficiency and the volume and how well organized everything was. And although I know that McDonald's was the inspiration for Dr. V, to me, this was like Disneyland, the magic kingdom, where the impossible, doing 14 cases an hour for a cataract surgeon, could come true. So the first lesson, of course, that you've given us is that your model is the way to eradicate cataract blindness. And based on what I learned from you, I wrote 15 years ago that our greatest challenge in cataract surgery is not an accommodating IOL, but rather the growing backlog of cataract blindness, the leading cause in the world. And we know that's because there are far too few cataract surgeons in most developing countries, so there's this need to maximize their productivity through high volume rapid surgery, but that has to be safe and effective for the very, very advanced cataracts. And of course, it has to be affordable and cost effective. And this really was all part of Dr. V's vision, how to solve this problem. Unfortunately, he had the foresight to have a very large family and a very talented family tree to carry on this work for future generations. You all know your model is emulated worldwide in all countries at all levels on how to do this. So returning to the United States, I was just so excited about this work and manual small incision. But I quickly became aware that this excitement wasn't really shared worldwide. And there were countries in South America and Asia where, in fact, there was sometimes disdain toward manual small incision. say in a country like Mexico, some of the leading ophthalmologists, of course, practice phaco, and they would tell the health ministers, we should be offering phaco, the gold standard, to everyone. And we shouldn't be doing something just because it's less expensive that isn't as good. So when Jeff Tabin and Sandik Ruit invited me to participate in this randomized controlled trial, I knew that this was an important project to undertake. The trial involved recruiting patients from Kathmandu itself so that all of these patients could be transported to Telganga for their follow-up exams for a year's time. But to mimic what happens with an outreach, they were all transported to a monastery in the foothills nearby. It was about an hour-and-a-half drive. We transported the patients there, and they had an extensive preoperative exam. They had a retrobulbar block, and then during the course of a day and a half, they were randomized to either having phaco with an American surgeon or manual small incision by Dr. Ruit. This was Dr. Ruit's makeshift OR from a classroom, and I similarly had my classroom where they managed to get an American phaco machine and microscope carried up to this rather tall foothill, and I used American IOLs and viscoelastic. Now, I had been on a plane for about 34 hours the night and arrived the night before. So here I was engaging in this competition with Dr. Ruit as the Nepalese master, and here comes the American challenger, and this is what we had to deal with. Because as you can imagine, in this outreach population, most of the cataracts were very, very advanced. The patients all stayed in this prayer hall, with pre-op and post-op. And what was important is in the ensuing year, they had very careful follow-up done at every follow-up visit. So, of course, what were the results? As you might imagine, when you factor in turnover time in the surgery, manual small incision was faster than the phaco. But really, my concern flying over there was the complication rate. I was a little worried about what this might do to my reputation when we published the results if David Chang had a 20% rate of drop nucleus. So I was fortunate that as challenging as these cases were, I did have one complication, but it actually took so long to deal with, about 45 minutes, that I was in danger of not completing the study in the day and a half that we did. But what it really taught me is how difficult the cases are. So my patients had more corneal edema early on. Now, it fortunately did clear, but that explained why their first post-op-day vision was not as good. And this is important because in this population, they don't understand the concept of rehabilitation recovery rate. And for many patients, they don't really want to have surgery until they talk to the patients that had surgery the day before, and they want to see how their friends are seeing. Because we both operated temporally, astigmatism was relatively similar between the two groups. And here's the uncorrected acuity at 6 weeks, looking at 20/60, and it was really the same. And that was true also whether you look at 6 months or even out to 1 year. Now, if you look at best corrected acuity, again, there was no difference at 6 weeks or 6 months. By a year, my group was a little bit better because there were more patients with SICS that were losing vision, and that was due to PCO, because Dr. Ruit was using an envelope capsulotomy with the round edge PMMA. I had a overlapping capsulorhexis with a square edge foldable IOL. So we concluded that manual small incision was faster and more cost effective. It was comparable in terms of astigmatism and safety. But there was little doubt in my mind that this was a better procedure for these really brunescent cataracts. It was better for the cornea. And, these people had a poor tear film, lots of pannus, and it was really a nightmare for a phaco surgeon. Well, I highlight this as lesson number one. And lesson number two really is that the manual small incision, I think, is a better procedure for most surgeons in the world for advanced cataracts. Dr. Venkatesh and I published a randomized control trial of the two procedures for mature cataracts, and Dr. Haripriya and I looked at the complication rate in 1 year at Madurai, 80,000 cases, comparing the two procedures for complications, but also looking at how different groups of experienced surgeons did. And we're able to do this because of your amazing electronic healthcare record system. So if you look at these 80,000 cases, you see that the complication rate was pretty darn comparable. And here it is overall. The staff, of course, are very experienced at both procedures. But if you start looking at less experienced surgeons, the phaco complication rate in the light purple starts to rise and ends up being highest on the visiting trainees who from countries such as Sub-Saharan Africa and Southeast Asia are going to go home and be a primary cataract surgeon in their location. So even though it looks good in the hands of experienced surgeons, with less experience, the complication rates go higher. And more importantly, this is a problem if you don't have cornea and vitreoretinal subspecialists to help you with decompensated corneas and drop nuclei. And we concluded that really in developing countries, surgeons really must master manual small incision before proceeding to phaco. Just one example, this is Dr. Tilahun, who is the highest volume surgeon in the country of Ethiopia, doing beautiful manual small incision on this type of population. This is an outreach camp where in settings like this, I was able to learn manual small incision. Here I am with Jeff Tabin. And this allows me in my own practice in Silicon Valley to do this several times every year. Here's a black cataract with a fixed small pupil, very shallow chamber. And so I'm so happy that I could do, in this case, a can opener, expand the incision, remove this manually, and then place, in this case, a PMMA IOL, and I elected to close it with one suture. But this was basically much more gentle on the cornea, reduces the rate of posterior capsule rupture, and I'm convinced that in countries, even like my own, where so many surgeons only do 200, 300 cases a year, they don't do phaco and a lot of brunescent lenses, if they were able to do this technique, it would give superior results. Well, PCO, as we know, in the West is an inconvenience because we do a YAG capsulotomy. But in developing countries where many of the patients have limited access to long-term follow-up, it's a leading cause of visual disability. And so the ability of Oralab to put a square edge on their PMMA IOL for very low cost has been remarkable. And in this published study that we did, this is Dr. Haripriya doing 50 patients in which she implanted a square edge PMMA in one eye and a round edge in the other eye of the same patient. She did another 50 patients that got a square edge PMMA in one eye and an Acrosoft square edge in the other. And what was remarkable is we did this study out for 9 years with digital retroillumination photographs, the only study of its kind in the literature with this kind of follow-up. And these are just 2 patients. And the side with the square edge PMMA is in green. On the first patient, the other eye had the round edge PMMA, and the other eye of the second patient at a square edge. And you can see out at 9 years how clear the square edge PMMA side remains. So the square edge PMMA is in blue, and you can see a big difference at 5 years. And I think we were really surprised to see how the difference keeps climbing all the way out to 9 years. Again, no such study in the world's literature. And it suggests it's just a matter of time before these patients get some level of PCO. This just shows the Acrosoft group in green. So the PMMA square edge did even better than the Acrosoft foldable, and that's because it has a continuous 360 square edge, which the Acrosoft does not. You can look at this as a survival curve. It's flat with the square edge PMMA IOL, but with the round edge PCO is just a matter of time. The fourth major lesson is you've shown the world that intracameral moxifloxacin is both safe and effective. We know that this topic is still controversial. Here are some of our review articles. But when you look at the Cochrane database, we don't have strong level 1 evidence, only one randomized controlled trial. But they concluded that because of the impracticality and large expense to do a huge trial for such a rare complication, we had to look at other sources of evidence to make informed decisions. And one such thing is retrospective data. There's an excellent editorial by Javid in which he highlighted the problems, how large and expensive such a trial would need to be, and would that make the end product too expensive to be practical. And it was in that issue of Ophthalmology that we published the first trial done at Aravind. This looked at manual small incision patients at the Venkataswamy Hospital in about a year. As you know, the manual small incision with the larger incision have always had historically a slightly higher rate of endophthalmitis. And we showed that the rate dropped from 30 cases to 6 cases in equal numbers of patients. And this was an important study because of the fact that it's so much volume in just 1 year's time that it's so unlikely that anything else could have explained this drop in the rate. And of course, we used Oramox, which you use on multiple patients at a cost of roughly 15 to 20 cents a dose. And we concluded that in settings such as your high volume situation where others in the West might question, is this safe in terms of endophthalmitis, but certainly in outreach settings where we don't have good sterile environment, it certainly made sense to spend 20 cents to give all of these patients intracameral moxifloxacin, and Oralab does in fact supply that now for so many. Well, this prompted adoption system-wide of intracameral moxi, and we published the results when we had almost 30 months. And then just last year, we published the 8-year data, 2 million consecutive operations. We were honored that this received the award from Journal of Cataract and Refractive Surgery as the single best paper of the entire year. And really, all of you at Aravind who have been doing cataract surgery should share in this honor. Each one of these bars is a 3-month period of volume at Aravind. The dark purple is without intracameral moxi, the orange is with moxi, and the yellow is that 1-year transition period where the 10 centers or so transitioned over. And of these 2 million cases, you can see the rate went from 7 to 2 per 10,000. And that's shown here, 7 dropping to 2 per 10,000. Now, what's amazing is we now have data from the United States, the AAO IRIS registry, and our rate is 4 per 10,000. It's lower at Aravind. And this benefit was true whether you looked only at manual small incision or at phaco. And because even though you had a very low rate of posterior capsule rupture, we have now 28,000 consecutive PCR patients. And you can look at uncomplicated versus posterior capsule rupture, and you see that the latter increases the infection rate by 7-fold. It's staggering. Now, what about the group that received intracameral moxi? Similar number of complications. And again, posterior capsule rupture increases the rate of endophthalmitis, but it makes it less than half of what it would have been without the antibiotic. It's important also to look at this side, uncomplicated cases, because here many surgeons not using this, including in America, would say, I have a low complication rate, I don't see infections, but you need large numbers to see this difference. And look at the difference just with phaco alone. It's a 6-fold reduction in endophthalmitis with intracameral moxifloxacin. I think we can speculate that why the US rate is higher is that half of our surgeons don't use intraocular antibiotics because we don't have a commercially approved formulation by the FDA in the US. But this has been controversial, and we have gone back and forth in the literature with opponents such as from Baskin Palmer, and that has been an active debate. But to put this in context, again, in the world's literature, you can see the importance of the Aravind studies in terms of supporting and looking at moxifloxacin. And what makes a randomized study more valuable is lots of numbers in a short period of time where everything is done the same way, and that's unique to Aravind. Because, of course, the problem is that the longer it takes and the more changes are introduced, there's a chance that other things besides the antibiotic could have caused the reduction in endophthalmitis. And the current numbers, of course, in my mind, are the single best evidence for using an intraocular antibiotic. The safety data has also been important, and just this year we published more data, a study done at Aravind, bilateral eye study, in which we showed that the Oramox concentration, which is the 500 microgram injection, is in fact just as safe for the corneal endothelium. And even though it's not approved, we have our compounding pharmacies in the US emulate the Oramox formulation, and this is what I use in my own operating room. Well, the last lesson has to do with OR regulations and the waste that they produce versus the benefit. I co-chair a committee made up of experts from ASCRS and AAO and our Society of Surgery Centers. And it's because in the last 11 years, we've had an increasing level of regulations and intrusion into our surgery centers of newer and newer regulations. And we have had to, in this case, develop guidelines just for eye instruments to defend some of the practices on why we shouldn't be treated like endoscopy and orthopedic instruments. This study turned out to be very important because this all started with a crisis in the United States in about 2008. And one of the major regulatory agencies had decided that flash sterilization should not be done for all specialties routinely, only in emergencies. And this also applied to cataract surgery. Well, overnight, this meant that we would have to do a 1-hour terminal wrap cycle on every instrument tray. And some large volume centers would have to then purchase 20 new phaco handpieces and trays. And when our group of experts from AAO and ASCRS met with this commission, we were told, well, you don't have any evidence in the literature that what you're doing is safe. And it was true. No one had ever published the infection rate with short cycle sterilization. So I contacted Drs. Ravindran and Venkatesh and said, could we do a retrospective study? And sure enough, we did this, a year's surgery at Pondicherry, showing that using the short cycle, along with reusing other things, the rate was very acceptable. And this study, the first one published in this way, turned out to be critical, and has kept us for the last 11 years of having to abandon the short cycle. This continues to happen in 2014. Our government, again, tried to institute a rule of no flash sterilization. We are able to defend this once again. So this landmark study by Cassie Teal with Dr. Venkatesh and others and Alan Robin, I think is a landmark study looking at the carbon footprint of cataract surgery using life cycle assessment. So here is one phaco case in the UK. It has the same carbon footprint as driving an automobile 500 kilometers. Comparatively, at Aravind, it's 1/20th that. And part of the difference is that all the medical supplies and drugs at the UK are thrown out after one use. So I love this slide from Cassie Teal. One phaco's trash in the US compared to 93 from Aravind. And when you consider the importance of this, it's interesting, 10% of all greenhouse gas emissions in the US are from the healthcare sector. It's about 5% in Canada and in the UK. And realizing the volume of cataract surgery and the fact that it continues to grow, I think we really have to look at sustainability, not just financially, but environmentally. This is the Royal College of Surgeons. They put out a great issue a few months ago looking at sustainability across all of medicine. And we were invited to write an article, and we made the case that we can learn to be more efficient and sustainable if we look toward lower resource settings. And as you know, at Aravind, you cannot afford to be wasteful because that just means you can cure fewer blind patients. So here are these two landmark Aravind studies, one showing that the United States has a 20 times higher carbon footprint for phaco, and yet our infection rate is 4 times higher. And it makes you realize that all of this mandate to throw things out after a single use, which are intended to be lowering the infection rate, really is of unproven benefit, and if so, results in excessive surgical waste. What about TAS, inflammation, the other worry with reuse? Well, this is a study that we did during a period where there were 2 TAS outbreaks at Pondicherry, and we showed that overall, however, the rate was low and had good outcomes. And this is the only study in the literature that actually looks at the rate of TAS and doesn't just report on an outbreak. I've used my platform as a past chair of the cataract PPP for the Academy, for the ASCRS Cataract Clinical Committee, to editorialize about the fact that rather than having others add new regulations developed or aimed at safety every year, we have to use data to tell us whether this is really necessary. And Cassie Teal and I developed a survey for these 3 societies, also the Canadian Ophthalmology Society, in which we surveyed cataract surgeons and nurses. This was just published as a special report a few months ago, and I have a editorial in press that I was invited to write on this subject by ophthalmology. And we had more than 1,300 respondents complete the entire survey. More than 1,000 were MDs. 9 out of 10 were concerned about global warming. Strong majority feeling that our waste is excessive. Only 5% felt that it was appropriate. And if you look at what are the drivers of waste, these are opinions now, but certainly wasteful packaging, regulations from hospitals and our government about when surgeons have the discretion to reuse things, and then also manufacturers specifying single use, probably to limit liability, and of course it is more profitable for them. If you look at American surgeons' willingness to use on multiple patients topical or intraocular drugs or supply items, you'll see that there's a very unanimous consensus that we should be able to use topical drops on multiple patients, but it's pretty darn strong for intraocular medicines as well, and that includes even when things have to be compounded by pharmacies or in the operating room. And then taking our cues from Aravind, this is willingness to reuse the tips, the tubing and irrigation, cystotome, willingness to reuse cannulas and blades and retractors and sutures. It's very high. So we had a strong consensus that OR trash is excessive, that we need more reusable options. Interestingly, if you're given the choice between a reusable and a disposable instrument that costs the same, 10 times as many surgeons would take the reusable one. We clearly want more discretion to reuse things and manufacturer consideration of carbon footprint. And although forced upon you this change in some of the practices, such as reducing the number of patients in the OR. And this is going to yield very valuable data on not whether this changes the COVID rate, but does it change the endophthalmitis rate, and will give us even more data looking at some of these practices. So, in summary, these major lessons, we now know how to stem avoidable cataract blindness, and it means going low-tech with manual small incision. And we would all do better, especially given our lower volumes with advanced cataract, to adopt manual small incision more often. This simple and low-cost modification is now on all ORLAB IOLs. So it's reducing the PCO rate not only at Aravind, but for all of the developing country settings where you supply their IOLs. And you have provided the absolute best data on endophthalmitis prophylaxis. And in my mind, this has settled the argument and the controversy. But you've also compelled us to look at how we will need to be more sustainable. And we've taken that survey, and next week our task force will meet with representatives from the major manufacturers, Alcon, J&J, Zeiss, and Bausch, who, based on that survey, have pledged to collaborate on looking for ways that we can be more green and more sustainable. It's fun for me to look back on this photograph from 2003. I think as long as we wear our hats and masks, we can make the argument that we all look exactly the same. But from that, it's who would have thought that so much fruitful collaboration could have resulted. This is a list of peer-reviewed publications that I have co-authored with all of you. And the last on the list, number 20, was actually just accepted on Tuesday. This was leaving on my last day at Pondicherry. And although I had come to teach phaco chop, I was so excited. We were discussing a lot of ideas, square edge and the PMMA. I was using intracameral Vanco, and I said, you know, think about this because everyone will wonder about reuse and infection. We talked about should we develop multifocal lenses, and I said the ultimate inefficiency is doing both eyes at the same time. And Dr. Haripriya at Chennai is starting a pilot study now as we speak on this. But I want to conclude by acknowledging how grateful and fortunate I have been to be able to enjoy such a meaningful association with all of you. And however unplanned and unexpected this relationship has been, it's been the highlight of my career. On behalf of my wife, Victoria, and myself, I want to thank you for this treasured friendship that we have. And on behalf of our profession and all of ophthalmology, we want to thank Aravind for teaching us so much and for inspiring us. I have to think that somewhere up there, Dr. V is smiling on his birthday and beaming with pride at all that has been accomplished in these past 16 years. But I think we also know what he would say. He would say, don't be too satisfied with all of this success because there's still a lot more that remains to be done. Thank you again very, very much for this wonderful honor.
Thank you, Dr. Chang, for the excellent lecture. Certainly inspiring to hear all the great work of the front runners from around the world and the best practices. It has been indeed a blessed day filled with humanity, and to the success of this celebration today, there are many behind the screen contributing their time and efforts. It is appropriate that we have a formal thank you note from Dr. Venkatesh, the Chief Medical Officer of Pondicherry.
A journey of 1,000 miles begins with a single step. And with our mission to eradicate needless blindness, Aravind Eye Care System has been always paving the way to reach the unreached. Today, on the occasion of Dr. V's birth anniversary, we remember in gratitude all those who are instrumental in this journey of us eradicating needless blindness. I would first like to take this opportunity to thank our trustees and the Dr.G. Venkataswamy Memorial Oration Committee for honoring Dr. David Chang with this prestigious award. Thank you, Dr. Chang, for this inspiring oration, and we thank you from the bottom of our heart for being our good friend who is always ready to help and support, a wise philosopher whose valuable insights led to the success of several of our projects, and always a caring guide for leading us in the right direction, including the 20th publication, which just got accepted a couple of days back. You are more than a mentor who constantly motivates us to improve and excel. My heartfelt thanks to Dr. Chang and his wife for their unconditional love and support over the years, not only for me, but for people across Aravind who have visited him in US or traveling with him. I take this opportunity to thank our DTP team for the tireless efforts in inviting guests for this online session, and also our audiovisual team in making those brilliant videos, and for the hard work behind the seamless telecast of the award function. Thank you, one and all.